for today is about accountability and performance in implementing a new strategy for patient service. In New Zealand, a shortage in publicly non-urgent medical and surgical service funding is always exists, as there are always more patients than they could cope with. But New Zealand is not the only country facing this type of challenge. The public health system around the world continue to struggle to prioritize patients' needs and balance the demand for scheduled service. Moreover, long waiting lists for publicly funded scheduled service not only have bad impact on patients, it will also result in a negative effect in New Zealand's international reputation. The long wait lists are considered as a country's health system are performing poorly. In order to fix this issue, New Zealand government released a new strategy in March 2000. Instead of their old booking system, the basic element for this strategy is to ensure that patients will be booked for FSA and treatment within 6 months, even when patients are booked at a short notice. Few years after the strategy was delivered, according to the public statistic, now 89 to 95% of patients receive scheduled service within 6 months is a good result compared to the previous one. The implementation of strategy has provided increasing certainty that patients who offer scheduled service will reduce their waiting time within 6 months, but still 10% of patients did not receive any treatment within 6 months. So prior to 2000, people frequently distrusted their DHB's performance. They were found that they were not confident that their family member would deal with fairly or in a timely manner. After the strategy was introduced, it mainly set out suggestions for DHB to improve their booking system and their management of scheduled service so that patients could be more confident and receive more detail related to treatment for their families and themselves. DHBs are expected to perform more effective and efficient to match the number of patients accepted for scheduled service to their resources. To monitor whether DHB has met aspects of strategy after they implemented it, the ministry using 8 elective service patient flow indicator as their performance indicator.
Okay, ESPI1. It measures whether DHB service has a proper relation acknowledge and the process of patient's referral within 10 working days. This indicator requires all DHBs fully comply with it. The results from this performance indicator shows all DHBs has complied except 2 of them, Huckabee in July 2009 and the Southland DHB in June 2010. ESPI2, this indicator is used to monitor how many patients waiting longer than 6 months for their FSI. The criterion is to keep it up to 1.5%, and the result is no DHB could ensure that all patients receive FSI within 6 months, but 7 of DHBs has exceeded 1.5 rotation 9 times. In 2006, the proportion of patients seen in June who were seen within 6 months was 78% for surgical patients and 82% for medical patients. Since 2007, performance has stabilized at 87% to 91% for surgical patients and 90 to 93% for medical patients. ESPI3, there are a number of patients whose priority score has met or exceeded the threshold but has not received any treatment within 6 months. These patients should be given a commitment to treatment. ESPI3 is used to monitor this type of patients waiting without commitment to treatment, whose priority are higher than the DHB's minimum treatment threshold. The goal for this indicator is to make sure every patient who meets the threshold will give certainty of treatment, but a small variation of 5% is allowed. According to research, all of DHBs have achieved the 5% standard, but only West Coast DHBs and Tarawahiti DHB have achieved the goal during 2009 to 2010. At the end of each month, the number of patients waiting without commitment to treatment average was 843. ESPI 5. Even if patients has given a commitment to treat but actually not treated within 6 months, EXPI 5 allowed up to 4% of the circumstance, and only South Canterbury DHB has exceeded the level of acceptable variation in 2 months. From 2008 to 2010, 89% or 90% of surgical patients were treated within 6 months. From June 2008, 95% or 96% of medical patients were treated within 6 months. The total number of patients who had waited longer than 6 months for treatment did not significantly change, but the pattern of when patients were treated did change. EXPI 6. This provides a large variation up to 15% of patients in active review who have not received clinical assignment within last 6 months. Of the DHBs using active review, none of them ensure that all patients were assessed on time. The total number of patients not seen on time each month ranged from 177 to 297, and the average is about 216. The level of acceptable variation was exceeded in 9 months by Mid-Center Health DHB and in 1 month by Heart Value DHB.
So the ESPI results for the year 2009 to 2010 shows at the end of each month, 3,500 to 5,500 patients did not receive their FSA within 6 months, compared to 3,462 previously, and 2,700 to 3,600 patients were not receiving any treatment within 6 months, compared to the 3,520 previously, and 6,200 to 9,100 patients had waited longer than 6 months for a service that they were told to expected within 6 months. Initially, the number has increased because the demand for treatment has increased. More patients were seen at an FSA now, but since 2007, the rate of improvement in providing treatment within 6 months has slowed. So there's a question from Group B. And using the strategy that were implemented, why does it take 6 months for this strategy to be achieved? What are some of the impacts of if the strategy are not achieved? So, if patient has not received any treatment within 6 months, and the patient, the situation will become worse, and they will suffer more illness. And yeah.
Hi. Are we talking about accountability? Yeah, first of all, there were 4 strategies that are introduced to counter the waiting times for public hospital elective services. These 4 strategies are the patients wait no more than 6 months for their first assessment with a specialist, that all patients with a level of need can be met within the resources available are provided with surgery within 6 months of assessment, a level of publicity funded services that ensure access to scheduled services before patients reach a state of unreasonable distress, ill health, or incapacity, and national equity of access of scheduled services, which means that patients with a similar level of health need and ability to benefit from treatment have similar access to scheduled services regardless of where they live. We will be talking mainly about 2 points, which are give patients certainty and achieve nationally consistent clinical assessments.
In this part, I will talk about the nationally consistent clinical assessment. Here it is mainly discuss the purpose of this assessment, the method used to select patients for FSA, and whether patients are selected consistently. Moreover, it will discuss auditing selection decisions and priority scores in setting minimum service level for access to scheduled service. For the purpose of the national assessment, it shows they are comfortable to ensure national equity of access to scheduled service. The national equity of access means that patients with a similar level of need and ability to benefit from treatment and will have similar access to scheduled service, regardless of where they live. Two sets of national tools are needed. One set is to select patients for FSAs, and the other set to prioritize patients for treatment. These tools would help to ensure that specialists make consistent decisions about patient care. Patients most in need of service receive them first. Fertile or marginally beneficial scheduled procedures are not provided. There are 3 methods for selection. The first method involves single individual, which shows responsibility to per patient by using a specific selection tool. The individual might telephone the GP to find out more information about the patient and discuss care or treatment options available in the hospital or the community. If this individual declines a referral, they might tell the GPs when the hospital would accept any new referral for the particular patient and or similar patients. The second method is more commonly used when the number of referrals to department is small. This is mainly responsible for all referrals to improve the effectiveness and efficiency of the scheduled service system. The third method involves hospital departments allocating the responsibility for selection referrals to the on-call specialist, who may or may not use selection tools. On-call specialists generally fit this selection work around their other duties, such as outpatient clinic, ward round operating theater sessions, or assessing patients in the emergency department. This method was more commonly used by surgeons and less often by physicians. These surgeons were confident that their colleagues select patients consistently, even when they were not using selection to deal with GP's refuse. Whether patients are treated in priority order, consistent access to scheduled service by a specialty could be promoted if credible national tools were available. Analyzing the data collected would help specialists to know whether consistent access was being achieved throughout the country and what needs to occur to improve consistency. For the auditing selection, in order to evaluate the effectiveness of accountability of their prioritization process and system to improve their quality where required, DHBS occasionally complete work of auditing. This is usually in response to a complaint or because a new manager or clinical director want to them whether change to a service are needed. For doctors' accountability, they should with reason provide adequate information to their patients about their assessment and available treatment. The specialist is responsible for overriding a patient's score as needed to respond to a patient's circumstances. There are two ways for setting minimum service. Firstly, taking more patients into system, then they have the resources to deliver scheduled service to within 6 months. The invitation rate are also one way to substitute for consistent national data about priority scores. In conclusion, the actions to implement the strategy are to introduce national consistent assessment tool developed by the specialists who will use them. The tools are to be continually improved using research, which shows the responsibility for all the patients. Data collected through the tools is to be used to improve national equity of access to scheduled surgery by targeting by funding to patients with the highest needs.
Giving patients certainty. One of the most important findings for the strategy was that while the patients waited to get assessed, they were not provided with basic information. This includes expected waiting times, options for care, and who was responsible for their care at the various stages of the process. This lack of information contributed greatly to the perception of poor service from the public health system. In response to this, strategies were set out. The strategies were that patients will know within 10 working days of the DHB receiving the referral whether they will receive access to specialist advice or treatment, will be given an FSA within 6 months of their referral being accepted, will receive treatment within 6 months of it being offered. Another plan was that general information about scheduled services needs to be easy to find. The ministry has issued a series of brochures outlining what public can expect when seeking publicity funding scheduled services. The current brochure was released in 2008 and is called A Guide to Elective Services at Public Hospitals. It has already been 7 years since then. Maybe a new brochure is required. It is also available on the ministry's websites in 7 languages: English, Chinese, Cook Island, Maori, Korean, Maori, Samoan, and Tongan. The ministry's websites contain useful information about the strategy, define technical terms, and provide a lot of information about the data that the ministry uses to monitor the flow of patients through the scheduled service system. The strategy is available from the ministry's webpage for publications released in 2000. Issues of certainty. Knowing whether GPs have asked for specialist advice or an FSA. One issue is patients are scheduled for an FSA by mistake because it was not clear to the DHB that a GP meant to ask only for specialist advice rather than an FSA. Unclear requests can delay matters for that individual patient, but can also prevent other patients from accessing scheduled services. Ensuring that individual patients with priority are given a commitment to treatment. Some patients' priority scores meet or exceed the DHB's threshold for treatment, but for whatever reason, they are not given a commitment to treatment within 6 months. All patients with priority scores that meet or exceed the threshold are meant to be given a commitment to treatment. The number of patients who do not receive a first specialist assessment or treatment within 6 months. Patients waiting more than 6 months for a first specialist assessment or surgery at 30 June from 2001 and 2010. This shows that there has been patients waiting for more than 6 months for an FSA has decreased a lot, and also patients waiting more than 6 months for patients waiting more than 6 months for an FSA has decreased, and patients waiting more than 6 months for a treatment has also decreased. This shows that number of patients receiving a surgical first specialist assessment after 6 months has greatly decreased. So after 6 months, less patients are receiving services, and most patients are getting services within 6 months. To conclude, although waiting times seem to be improving, however, these are just quantitative measurements from 2010 data. It will be good to see what the most recent measurements are. Also, we are not sure whether patients are satisfied with their treatment or whether the correct patients are getting their treatments treated within 6 months. And if we wanted to gather this information, how would we do so? Is it possible for DHBS to have only one-off audit assessments? Why only one-off audits? I think one of the reasons for it to have only one-off audits would be because DHBS is quite a big organisation, and it will take quite a long time for it to get fully audited and produced onto paper. Could be more than a year, and I think that's another reason why a lot of the data information it's not outdated, but it was a few years ago. So the reason, I guess, for not having just one-off audits would be just in terms of the practical side of things. It would kind of be hard to implement if they had multiple audits.